didactic lecture. In the end, I'm going to show you a couple cases just to see if you can kind of figure out what you've learned from this lecture. And then we're going to finish with a couple Sam's questions as well. Okay, so to start, just some disclosures. This is for the entire meeting. And so for these learning objectives, we're going to look at the MR findings of labral tears. So specifically, we're going to look at SLAP tears, which stands for superior labral, anterior, and posterior, Bankart lesions, and a couple variants. And then we're going to just talk in the context of instability. So labral tears really are an interesting type of subject, and we put a lot of value onto the MRI. But the reason why this occurs is because the shoulder really is a very shallow and unstable joint. And because of that, we look at the structures, look to see which are the stabilizing structures, which ones are mobile, and there are no stabilizing isometric ligaments all the way around the joint. It's not a uniform structure. So because of that, there is glenohumeral incongruity, and that's why we're getting the instability over time. So with this, you can have labral ligamentous pathology, your joint capsule can be very capacious or lax, and you can also have osseous involvement when you have anterior shoulder dislocations. Okay, so when it comes to shoulder instability, what's causing that? So one of the more common reasons is trauma. So a person falls on an outstretched arm typically. They have typically an anterior shoulder dislocation in the vast majority of cases, but you can also have posterior less commonly. But repetitive strain from activities, multidirectional instability, these also occur without one event that they can remember with trauma. So one of the acronyms you may come across in the literature is AMBRI. So this is atraumatic, multidirectional, bilateral instability. So this is something that's not going to go to surgery. This is something where they typically go to physical therapy and they usually improve. So with microtraumatic instability, repetitive overhead sports. So putting these patients into a lot of stress, abduction, flexion, internal rotation. If they keep doing this, typically in the overhead throwing sports, they can cause some instability. So with this, we want to look really carefully at all the labral ligamentous structures, especially posteriorly. So in MRI, we're going to look at the joint capsule itself, the labrum, of course, because that's our focus of this talk, but also you can have rotator cuff tears, which is going to be covered as well. So looking at shoulder pain in the throwing athlete, this is really the most common offender. So in the US, baseball is very common. If you go over to Europe, especially UK and India, they love cricket. But any of these sports where there's an overhead throwing mechanism, it's going to cause the same damage to the shoulder, specifically the labrum. So when people are throwing overhead, it's a tremendous amount of force that's going all the way to the point where there's an abrupt stop of that throwing motion. And because of that, there's velocities up to 7,000 degrees per second. This is a tremendous amount of force, and when this stops, there's a lot of pulling forces on the labrum and the ligamentous structures. So when we're talking about labral tears, the definition of labral tears is either it's detached, or there's abnormal signal within it, or there's contrast if you would do an arthrogram or fluid extending into the substance of the labrum. So these are all what we're considering to be labral tears. So if you look at the glenoid and fossa, you're trying to look at the clock position. And depending on the surgeons, it's different. So some surgeons believe the anterior shoulder is going to be in this position, in the 3 o'clock position, whether or not it's left or right. Some surgeons will look at the shoulder from the side and say, that's the clock position, left or right. So it's a little bit confusing. Just make sure that you're communicating. I will specifically say it's in the anterior inferior quadrant, parentheses, whatever clock position that's going to be. But when we're doing that, you want to make sure that you realize the top of the shoulder is going to be the 12 o'clock position, and it's not straight up in the gantry. It's relative to the biceps anchor. Okay, so looking now at some normal variants. So these are things you might see, but you need to identify these and not call these superior labral tears. So the first thing is the sublabral recess or sulcus. So with that, It's a very smooth, thin structure that's going supromedially. So as you go up, it's going medially and paralleling the glenoid. So if you look at that, this is not to be confused with the labral tear. Here's your anatomy. Here's the labrum. Your biceps tendon comes off there, right off the supraglenoid tubercle, and it's very thin. Okay, so sublabral foramen or the hole. This is when there's lack of attachment of the labrum. So we don't dictate it as detached because in that anterior superior quadrant, this is the land of normal variance. You should be very cautious if you're ever going to call any pathology in this location because most often it's going to be a normal variant. Okay, so this is what it's going to look like on an MRI on a sagittal view. You can see that there's contrast on this image going underneath it. So it's completely non-attached, and this is what we call a foramen. If you look on your axial image, if you look at the cross-hatching with your sagittal view, make sure you're in that anterior superior quadrant because sometimes it's a little bit confusing when you're crossing that midline portion, but this is superior to the midline, and this is the foramen. Another thing is the Buford complex. So what this represents is two things. So this is an anterior superior labrum that's absent. And then we also have a thickened middle glenohumeral ligament. So there's three focal thickenings of the anterior and the anterior inferior joint. So those thickenings of the capsule we call ligaments. There's a superior, middle, and inferior. So the middle glenohumeral ligament comes very closely aligned along that superior labrum. And this is what it's going to look like on a sagittal view, just a very focally thickened ligament and absent attachment. Okay, so when we're looking at what's true pathology, the ABER view is something that you need to be aware of. So ABER stands for abduction external rotation. So essentially what you're having the patient do is take the palm of their hand and put it behind their head. So when they do that, they're really stretching out that anterior inferior joint capsule, and that's where the Bankart lesions and the Bankart variants occur. So that's really important to really focus on that spot. So when you pull on that, you can imagine you're allowing contrast if you did an arthrogram or joint fluid if there is an effusion to really nicely go into these crevices and to make it more conspicuous. This is an example of an anterior inferior paralabral cyst. So if you ever see focal fluid collections next to the shoulder, next to the knee or the hip, you have to think first off, is there a reason? Could this be communicating with the joint space through a soft tissue defect? And when it comes to the shoulder, you have to presume this is a labral tear until proven otherwise. So this is something that these can track along the path of least resistance. They can go along nerve pathways, and they can cause mass effect. So when you see these, you first off have to recognize that there is a labral tear. And then second of all, you want to look at the adjacent structures. You want to look at the infraspinatus. So here's the infraspinatus. You want to make sure that nothing next to this is causing injury to the nerve. You're looking for signal changes within the muscle. Early on, you may see some edema. It may be bright on T2 weighted imaging. And with time, you may have a lot of focal atrophy of that muscle. Here's another case. But in this example, the location's more important. So if you look at this is centrally located right within the suprascapular notch of the glenoid. So this is where the suprascapular nerve runs. So this is very worrisome, and you of course want to look at the adjacent supraspinatus and infraspinatus because in this location, if it's in this more superior position, it can actually affect the nervous supply to both the supraspinatus and the infraspinatus. Okay, just want to show you an example of a posterior labral tear. So we like to always look at the labrum tangential plane to where we're seeing it. So if it's posterior, I like to cut straight through on axials to really get a good feel in cross-section for pathology. And here is showing you multiple different reasons why you're very confident this is a labral tear. So very carefully, you can see that there is detachment. So between the triangle itself and the glenoid, you can see there's tracking of fluid. And then in addition here, you see a little small focal multiloculated fluid collection. So this is your paralabral cyst. Here's a different case, detachment all the way back. You feel very confident. It doesn't have to go all the way through the capsule. You just want to make sure it goes all the way through the junction with the cartilage next to it. So if it gets deeper, goes deep to that, that is a definition of a tear. Here's another example, and I want to point out that if you do an MR arthrogram, you may not always have contrast within your paralabral cyst by the time you image. So if you're very efficient, you inject them, they immediately go into scanning. It takes a little bit of time because these paralabral cysts are typically pretty mucinous and thick. So because of that, they don't always opacify. So just a word of caution, make sure you're always including some type of fluid-sensitive sequence in your study. So either proton density or T2, really trying to pick this up if it didn't opacify. Okay, moving to SLAP lesions. So these are those superior lesions that, relative to the biceps anchor, they go anterior and posterior to that. So if you look in the literature, there's 10 or more types of SLAP lesions. You really don't need to know all those. I think you can just reference those if you want to kind of get a little bit more interest in it or if you want to be specific. But I just caution you to always be descriptive in your reports. Don't just say SLAP 7. Otherwise, you're going to be getting a lot of phone calls on that, even including the surgeons. But what is more common are the first four. So I think it's reasonable to be aware of this, to know what you're looking at. So type 1, this is just really a little bit of fraying, very early changes of degeneration of that superior labrum. So, if you don't have a great quality scan for multiple reasons, if the patient's moving, if it's one of your low field where you just don't feel like you've got good quality, we could be missing these lesions. But on a 3T or a good quality 1.5 with a great coil, you can see a little bit of irregularity of that, and that's a type 1. The most common lesion is the type 2 SLAP lesion. So this is what we see most of the time, and this is avulsion of the superior labrum and the biceps anchored together. So it gets pulled off, but you want to make sure you're looking at something else, the long head of the biceps. So look at that intra-articular portion. You want to make sure that there's no involvement of the actual biceps itself. Okay, so just getting some examples here from Dr. Stoller's book. This is an example that was proven of a type 1 SLAP lesion. So it's just, if you compare it to the more inferior labrum, which is low signal intensity, triangular, this is just a little bit more intermediate signal intensity, a little bit irregular margins to it. Now keep in mind that you always have to keep in mind that with magic angle effect, if you're angled about 55 degrees to the bore of the magnet, on low level, so 35 milliseconds or less. So if you have a T1 or a proton density image, you may actually get increased signal where it's not true pathology. So you want to also correlate this with your T2 weighted imaging. This is once again, the most common type of SLAP tear, the type 2. And this is completely different from the normal variants we showed you. So look how wide and irregular this signal is within that superior labrum. And look at what's left of the substance. This is not a black triangle anymore. It's just a little bit of an irregular wisp of peripheral tissue. So this is what it's going to look like on the schematic drawing from Stoller's group. And you're just pulling off the whole anchor itself, but there's no extension into the substance of that long head of the biceps. Okay, so just to show you this a little bit more schematically. So this SLAP 2 lesion, you're looking at the width of it. You're looking at the irregularity of the signal within that superior labrum. So to compare this to what a normal variant would be, this is the sublabral recess. It's thin, it's smooth, it's going supromedially. So it's going towards the head as you go upwards, paralleling the glenoid. And then here's the sublabral foramen, or the hole, where it's just focally not attached, and that's normal. Going to type 3 and 4, these are bucket handle tears. So think to the knee when you have the bucket handle tears, more commonly of the lateral meniscus. That's when you start to have migration of a torn fragment. So if you have a bucket handle tear through the superior labrum, it's going to start to droop into the more inferior part of that superior joint space. But with type 3, your biceps itself is going to be intact. Type 4 is when you start to have propagation of the tear into the biceps tendon itself, and usually it's going to be like a longitudinal split tear pattern. Okay, so here's an example of a proven SLAP 3 tear. So if you look at this drooping part of that low signal intensity focus, that is the labrum. So instead of being a triangle firmly attached to the superior glenoid, it's now drooping downward. And you can see why with the correlative dramatic drawing here. So looking at this from your axial imaging, this is not my preferred image, but it shows the point. This is going truly anterior and posterior to the long head of the biceps tendon. And that's really how we're going to use our terminology. And then finally, type 4, this is where you can see there's that drooping fragment into the joint space. But if you also look at a more distal extent, you can see that there's a split tear of the biceps tendon. So the two of those together make a type 4 tear. Another thing that's interesting is what we call a peel back lesion. So in these high-level athletes, specifically the baseball players where we're getting a lot of our cases, it's unusual, but you can imagine if you're a bird's eye view looking down at the scapula and looking at the long head of the biceps tendon, every time they cock their arm back and they move it forward, they're twisting their biceps tendon. And a lot of the force of that is really going to occur near its origin. So with that, you can peel back part of the labrum, a little bit of the soft tissues, and it becomes unstable. So what you're going to look for is internal rotation view and the external rotation view. It changes. But if you have an ABR where they're putting their arm behind their head, you're going to see that the labrum is now moved more medially. So if you look at the arrow here, this labrum normally should be extending beyond this line. So if you take a parallel line along the glenoid, this is a normal labrum, this is not. This is being pulled back because it's no longer firmly anchored. So think about this when you have your baseball pitchers. Okay, so moving now to traumatic instability. So patients who can report or you have a confirmed documentation with your PAC system with the radiograph if they've dislocated their shoulder. So once again, it's much more common to see the anterior dislocation. I can tell you posterior dislocations are missed a lot more commonly. So we don't see them often. Sometimes the patients can't get into a direct view that you'd like, but you don't want to miss this, so be careful. So when it comes to these Bankart lesions, there's a lot of variance where there's a little bit of difference as far as the integrity of the periosteum, the positioning of the labrum itself when it's torn, and whether or not it involves the anterior or posterior shoulder. So there are a lot of acronyms out there that you can look up. You can include those in your report, but once again, only in conjunction with the more descriptive dictation. So for example, PULPSA, this is a posterior labroligamentous sleeve avulsion, which is really the posterior variant of an ALPSA lesion, which we're going to get into a little bit further. Okay, so when we call a Bankart lesion, by definition, it's only soft tissue. So it's the labrum, it's the ligament. We're not talking about the bone. If you see an actual fracture, that's an osseous Bankart lesion. So when you have that, it's the anterior inferior quadrant, which is really where we're always very concerned about because the anterior dislocations create the impact and the damage there. So we're looking for the loss of either the shape or we're going to have the increased signal or the detachment within it. Okay, so these are axial images just to show you examples. This is a normal, and what we're going to do for the schematic is just kind of parallel this one little corner of the shoulder. So we're just looking at that anterior inferior labrum, the humeral head, and the glenoid. So when you're looking at a Bankart lesion, this is where you have the labrum is pulled off. It can also have signal within it. It can be fragmented, but there's something that's really abnormal about the labrum. But in conjunction with that, there's been disruption of the glenoid periosteum. So the scapular periosteum has been ripped, and because of that, it now is free to move. It's not going to scar back into place most of the time. It can, but there's no guarantee of that. So because of that ability to move, they oftentimes will go to surgery. When it comes to an osseous Bankart lesion, be really critical on your radiograph. Sometimes they're small lesions. This one's pretty big. I don't think anyone's going to be missing this, but you want to be able to try to quantify this. So if you look at your MR image on the left with the axial image, you want to give your dimensions, and you want to say how much of the AP dimension of that glenoid is affected, because the larger the lesion, the more likely they're going to redislocate again and again. Okay, Perthes lesion is one of the variants, just to go through that. So it's similar to a Bankart lesion, the fact that the labrum is torn or detached, but the scapular periosteum does not become transected. It just gets stripped back. So with that, the labrum can potentially go back into its anatomic location and then scar down without the need for surgery. So you want to, if you can, look very carefully at that very thin structure of the periosteum. And here's what you can see here. So a little bit of strip of the periosteum, contrast is going medial as well as lateral to it, but it looks great. It's intact. Now this is different from the Alpsa lesion. So with this lesion, the periosteum is still intact, but it actually jumps over the glenoid. It becomes displaced. And so when it does that, it's really difficult for it to now move back into its anatomic location and heal. So if it becomes displaced far medially or inframedially, it's not providing that added support structure to the glenoid. So the patient's going to be continually unstable. So this is what it's going to look like. So I'm showing you an ABRA view on the right and the schematic view on the left. So you can imagine it just kind of jumped ship. It just went over that hump, and now it can't get back to where it belonged. So in the acute setting, you can see there's a really thickened, stripped periosteum, and with healing, it can actually become glommed on to the more proximal part of the scapula. Okay, GLAD lesion, this is glenolateral articular disruption. So you want to always look very carefully at the articular cartilage because the damage is occurring in a broad area. So this can either become delaminated, it can go along with the labrum as you see here. So here's a piece of intermediate signal intensity cartilage attached to the labrum, and here's the defect, or you can have it just fragmented in within the joint space. If you look at your sagittal image, you can kind of get a whole lay of the land, how much of this is truly involved. Because you want to make sure you give the surgeon and the patient a realistic view. So if they go in there and just attempting to repair the labrum, it's not going to solve the issue of extensive cartilage damage. So try to quantify that with centimeters if you can. So in conclusion, for the didactic part, this is shoulder instability can be caused by either shoulder dislocation, most commonly anteriorly, repetitive strain, or microtrauma. So to diagnose the labral tear, you want to say, is it detached from the glenoid, or is there abnormal signal or contrast going into the substance of it? SLAP lesions were graded upon the involvement of the superior labrum, and it's relative to the biceps labral complex. So is that pulled off? Is there any bucket handle involvement? And is there any involvement of the biceps tendon? So look back at your references to really get a handle on those features in order to be most specific for your SLAP tear. Bankart and Bankart variants should be described according to the involvement of the labrum, but look very carefully at the periosteum. Sometimes we don't have a good scan, but it is critical in order to predict the likelihood that they can scar down without surgical intervention, and then quantify your glenoid cartilage injury. Okay, just gonna do a couple cases before we then go into the SAMS component afterwards. This is one of our baseball players who came to us. He does do multiple sports. He's 17 years old, and he was complaining of shoulder pain. So starting off, these are coronal images from an arthrogram, and we do typically do an arthrogram when it's a patient who's younger than 35 years of age. The question is instability or labral tear, and if they're a high-level athlete. Those are really our criteria. Okay, so as you move through the coronal images, I'm going to show you a couple T1 weighted images. Moving on to axial, you can see just the injection line from the arthrogram. Okay, then I'm going to bring up the most relevant image. So with this patient, what's the diagnosis? Do you think this is a normal variant? Is this a ruptured biceps tendon? Is this a SLAP tear? Or is this a partial thickness supraspinatus tendon tear? Okay, so this is a SLAP tear, and we're going to go through that. So this is beautiful. If you look at the SLAP tear, this is actually a type 3 SLAP tear, and this is where the triangle of black should be, similar to the inferior labrum, but it's fragmented. And in addition, it's starting to droop down into the superior part of that glenohumeral joint. But there's no involvement on the biceps as we scroll through those coronal images. Okay, and here's another patient, a little bit more extensive injury. So this patient has a long time history of being a baseball player, and he's had chronic shoulder pain. So as you look through these coronal images, and sagittal images, back to coronal, fluid-sensitive T2 sequence. And now we have your axial images. Okay. So as this comes across your PAC station, you have to think about how are you going to dictate this. And there's multiple features that you want to focus in on, especially relevant to this talk of instability in the labrum. Okay. So with this, what would you diagnose? Would you say this is an avulsed superior labral biceps complex? Is this an osteochondral lesion? Do you see cartilage delamination? Do you see just BNC, or would you dictate all the above? Perfect, excellent, great. So these are the complex cases where you're going, oh my gosh, what next? But just to go through it, do this systematically, and it's going to be a little bit easier when you look at these patients. So when it comes to overhead pitching, you already have that kind of clue that you want to focus in on that superior labrum. So I find the coronal images very helpful because you're tangential to the region of interest. So superior labrum, it's still regularly triangle position, low signal, but look where it's positioned. It's not snugly up against the glenoid. So this should be, if you compare it to the inferior, look at the cartilage. There should be a seamless interface between the cartilage and the black triangular labrum. As you go up here, it's nowhere to be found. It's displaced about a ½ centimeter laterally than it should be. So the biceps anchor is still snugly attached to it, and you want to look at that relationship as well. And then look at this. What is this? There's actually a piece of bone that's been pulled off. This is a unstable osteochondral defect. So when we say osteochondral defect, we're more commonly thinking the ankle, the knee, but it can happen here as well. And also look at how there's undermining of that cartilage. So this is delamination. So what we mean by that is that it's kind of a parallel layer of instability where it's separated off. So it can be within the substance of the cartilage, or in this case, it's undermining it. So these are all very relevant features. Okay, so thank you for that.